Welcome. Welcome, everybody.
Adjustment.
I want to remind everybody there's a reception afterwards, and you're all welcome to attend. So today's a day that we honor our friend and colleague, Michigan's physician scientist, Ed Schteingart. And let me start by just saying I'm delighted to welcome some of Ed's family who are with us today. Some are live and perhaps some are Zoom. But particularly Ed's wife, Dr. Monica Starkman, U of M faculty, and his children, Dan, Judith, and Miriam, welcome. I'm not sure if your spouses are watching, but Lynn, Matthew, and Patrick is here, welcome. And grandchildren, Zach. I said Judith. I think I said Judith. I did. And grandchildren, Zach, Alex, Ariana, Ethan, Etienne, Jacob, and Logan. So welcome. So each year I like starting out by recalling Ed's amazing career. Ed Schteingart came to the University of Michigan in 1959. Now this next slide is 1970. I used to quiz people here to name as many faculty as they can on this slide, but we won't do that today. I'll just remind you, and you can tell where Ed is though. Ed's on the right end of the front row with Jerome Kahn, our prior endocrine chief, who discovered the adrenal disease that now bears his name. Ed set out early on rather boldly to create the world's first multidisciplinary adrenal program. And in the final analysis, not only did Ed do just that, but he really helped create the very concept of a multidisciplinary clinic, where oncologists, endocrinologists, surgeons, pathologists, and geneticists all see patients together in the same clinic to create a unified diagnostic and treatment experience for each patient. Ed's work really was the foreshadowing of translational research and personalized medicine as we now define it. His program has grown into our current endocrine oncology program and the embedded adrenal team. Ed was really the solitary catalyst for the formation of this flagship program in Rogel Cancer Center, which now is shown here with a bunch of PIs engaged in work together. Later in Ed's tenure, he became a leader in the education of our junior faculty, serving as the director of our training program in clinical research and president of the National Organization of Directors of these groups. Ed was deeply committed to our Ann Arbor community, where he was not only the president of both Beth Israel Synagogue and the Hebrew Day School, but he also served as a board member in charge of development for the Ann Arbor Symphony. As I've often said before, the most notable characteristic of Ed Schteingart was his humility and his kindness. Ed was Millie Schembecher's physician, and he developed a unique friendship with Bo, Millie, and the boys. And with support from Bo, Ed established the first International Adrenal Cancer Symposium some 20 years ago. That has been the singular most important development for the facilitation for international adrenal cooperation to date. That meeting sparked a resurgence in adrenal biology and adrenal neoplasia work here and around the globe for many of us, including Tom Giordano and myself here today. So indeed, out of that meeting was born the first international trial for adrenal cancer, the formation of not one, but two international adrenal cooperative groups, NSAD as shown here, and the A5, that together aim to enhance collaboration in rare adrenal diseases and now serve as critical leverage platforms with funding agencies and big pharma. Indeed, our speaker, Lauren Fishbein, dear friend, serves as the current chair of the A5, which now boasts close to 50 institutions on 5 continents. So I hope it's apparent that I'm forever grateful to Ed for his leadership, his mentorship, his altruism, and his friendship. And I welcome you all to this special day. To honor Ed's vision for the adrenal community, there is no one better suited than our speaker, Lauren Fishbein. It's only fitting that Lauren speaks here at U of M on recent work on pheochromocytomas here where one of Ed's mentors, Bill Beerwaltis, first developed MIBG as a treatment for pheochromocytoma. So what about Laruen? Well, after an undergraduate degree in biochemistry at Vassar and an MD PhD at the University of Florida, she landed in Boston for an internship and residency in the Harvard system before heading to Penn, where she further developed her expertise in endocrine genetics and genomics, focusing on pheochromocytomas and paragangliomas. Indeed, it was some 8 years ago, perhaps, that we did our best to recruit her here to U of M. But instead, Laruen headed to Colorado, where she has been tremendously successful in establishing a top-tier adrenal program with a focus on pheochromocytoma, neuroendocrine tumors. Among her accomplishments in her 8 years at the foot of the Rockies, Laruen led the NCI's TCGA genomic project in pheochromocytomas that further galvanized her leading role as an endocrine geneticist. Laruen, in short order, has become one of the leaders in the global endocrine community. Laruen is Associate Professor of Medicine and Endocrinology with a secondary appointment in the Department of Biomedical Informatics, and she directs the Neuroendocrine Tumor Clinic and Research Program. Her own program focuses on investigating the interplay between somatic and germline genetics and neuroendocrine tumors with a focus on pheopara. And in addition to serving as the chair of the A5, she has served in numerous capacities in national and international societies, the North American Neuroendocrine Tumor Society and the Endocrine Society, where, among other roles, she will be the chair of the annual meeting in Boston in 2024. So mark your calendar now for that. Laruen also serves as a medical advisor for the Pheopara Alliance, a nonprofit patient advocacy group, and her research has been funded by the American Cancer Society and the NIH. With over 60 publications in her brief tenure at Colorado, Laruen is simply a superstar. Her studies seem always to be on the cutting edge of discovery and care. She's always illuminating. She's always elevating our field. She's increasingly a sought-after speaker at these national and international conferences of scientists and clinicians. In short, she is the go-to person, the go-to expert in pheochromocytoma paraganglioma. So you're all in for a treat, and I welcome Laruen to the podium at the University of Michigan.
Wow, I don't know how to really go after that. It's been a wonderful introduction. Should I stop sharing this screen? This one. Yes. And then we want perfect. Perfect. Is there a way to move? Yeah, we're gonna fix. And it will. Okay. Great. Perfect. Thank you so much. Okay, wonderful. So thank you for that really kind introduction, Gary. I don't know where you went. There you are. And I'm really thrilled to be here to see so many friends and colleagues. It was such a great adrenal group and endocrine genetics as well. So really happy to be here. Let's see. Okay, no conflicts of interest related to this talk, and here are the learning objectives. So as thrilled as I am to be here at the University of Michigan, I'm really, really honored and thrilled to be invited to give this specific lecture, the Schteingart lecture. It's the 10th annual, I am told, and I am speaking after all these giants in the endocrine field, which truly is amazing, and the second woman speaker, I will say. So I'm going to talk a little bit today about 6 degrees of separation. So I was not lucky enough to meet Dr. Schteingart, but you know how they say Kevin Bacon is 6 degrees separated from people. So I'm not sure it's going to be 6 degrees, but I'm going to talk about how we're a little bit separated. First, as I got drawn into all the PubMed articles, I realized that we have a love for the adrenal gland in all senses of the word, in all sorts of adrenal diseases. And I think we definitely shared that. On the website, it talks about collaborations with Dr. Starkman, thank you. And we actually have 6 degrees of separation here because my clinical adrenal mentor at Penn used to pull up these joint articles that you two wrote together all the time when we saw patients with Cushing's disease. So when I was a fellow in training, these were key articles she would pull up in relevant to the patients that we were seeing. So another degree of separation. Gary already talked about the ACC program and the adrenal oncology program here that he was so integral in creating, and developed that first conference with the first international guidelines. And I truly believe that led to Gary's vision for A5, and that he really created, and Toby was the inaugural chair, and I have the honor of being the current executive chair. So to me, this is another degree of separation in how we are connected. And then you might think that he didn't really do that much with Pheochromocytoma, but I found this case report from 1972 of a paraganglioma that was ectopically secreting ACTH, so that's probably where the real interest was, but still it was a case report on paraganglioma. So I thought for sure that's another degree of separation for us. So this is my launching point into talking about pheochromocytoma and paraganglioma. So most of us in this room and online know that pheochromocytomas are the tumors forming within the adrenal medulla. Paragangliomas are the tumors in the autonomic nervous system ganglia from the base of the skull all the way down to the pelvis, but under the microscope, they're the same thing. So we call them Pheopara interchangeably often. The clinical presentation we learn in medical school is the classic triad of headaches, palpitations, and sweating or diaphoresis. But really, patients can have all sorts of symptoms, including hypertension that can be sustained or episodic, orthostatic or relative. And patients can have a number of other symptoms related to the high catecholamines. And a lot of patients are asymptomatic. Sometimes their tumors don't secrete these hormones. And sometimes even when they do, the patient doesn't have symptoms. So how do we do screening for this secreting tumor? The key is plasma metanephrines or 24-hour urine metanephrines. The sensitivity and specificity are very similar now for them. The Endocrine Society guidelines recommend patients be supine, lying flat. That's not always practical. And so if you do them sitting up and the results are negative, you're good to go. If they're indeterminate, that's when maybe patients should lie down for a little while. The most common thing we see are these indeterminate results. And so what do you do with those? What I tell everybody is the first thing is we're going to look at your medication list if we haven't already. We're going to identify interfering medications. Some common ones are listed here. In Colorado, we worry a lot about marijuana because it's legal there, and we see a lot of false positives from that as well. So this is the first thing to always do. Once you do confirm, though, that there is a pheo or para, how do you image? I'm asked that a lot, and I always say, cross-sectional imaging, CAT scan, MRI, the nuclear medicine imaging is really important, but it's costly and very costly. At least at our institution, a dotatate scan is $26,000. You can really diagnose most of these on cross-sectional imaging unless you're worried about metastatic disease, or in hereditary conditions, sometimes you'll use the nuclear medicine imaging. Non-contrast CAT scan is really the best to diagnose a pheo. This study was out of the Netherlands, and they looked at 222 pheos, and they showed that if you can find the non-contrast Hounsfield units are less than 10, this is not a pheo. Only one of their cases of pheo had a Hounsfield unit less than 10. So this is a great way to distinguish adrenal adenomas from pheo, and I think the most important way. Okay, we're going to talk about the perioperative blockade. The Endocrine Society guidelines and the NANETS guidelines recommend alpha blocker as the first-line therapy, calcium channel blocker as second-line therapy. And how do you choose which alpha blocker to use? We used to use phenoxybenzamine all the time because it's a non-selective, non-competitive antagonist, but it is super expensive and extremely hard to get. So we use data from these two large studies. One is retrospective from the Mayo Clinic and Cleveland Clinic, and one is prospective out of the Netherlands, the Prescript trial. And basically, they found that there was similar efficacy between phenoxybenzamine and what I call the Zosins, doxazocin, terazosin, prazosin. And so really, I use Zosins, doxazocin for me for just about every patient that I see. Sometimes if they have astronomical levels, they've maybe already had a surgery that didn't work because of hypertensive urgency, I'll go out of my way to find phenoxybenzamine, but that's pretty rare nowadays. Okay, now we get to move on to what I think is the fun part, the genetics. So in medical school, hopefully they're not teaching anymore that these are the tumor of tens, but that's how they used to teach it. And they used to teach that because they used to say 10% of these tumors were hereditary, but we now know that up to 40% can be hereditary. So it's one of the largest solid hereditary tumors that exists, even though it's pretty rare. So it's still a small group of presentation. In children who have Pheo or Para, up to 80% have hereditary. And these mutations, these hereditary causes, come from over 12 susceptibility genes now. So back in the 1990s, there were only 3 genes known, NF1, RET, and VHL, and that's why it was 10% hereditary. But in the last 2 decades, we've identified so many more different genes that are involved with hereditary predisposition. And again, what I find fascinating and why I study this tumor type is these genes are located in completely different pathways in the cell and yet form the same histological tumor type. Why does that happen? How does that happen? Why do some contribute to more malignant, aggressive tumors and some don't? And so this endocrine genetics component, the hereditary genetics, is why I got so interested in studying these tumors. So I mentioned that up to 40% can be hereditary, and so we do recommend that all patients, any patient with a Pheo-Para, be referred for genetic testing, because it's going to affect how we clinically follow that patient, as well as their family members that may be affected by these pathogenic variants. So how do we differentiate when the patient is seeing us between sporadic and hereditary Pheo-Para? You can look for potential syndromic features like a young age, a diagnosis, a family history of these tumors, an extra-adrenal tumor, multifocal primary tumors, or other tumors or syndromes associated with the various syndromes. But please keep in mind that, again, 40% are hereditary, and even sporadic adrenal pheos with no family history, up to a quarter, can have a hereditary component. Solitary Pheos or Paras, up to 30% can have a hereditary component. So we really cannot tell clinically necessarily that there's a hereditary component. So all patients should be referred for clinical genetic testing. If I give any clinical takeaway today, that's my clinical takeaway. All right, so let's talk about these predisposition syndromes. The first one, neurofibromatosis type 1, it's near and dear to my heart. This is what I actually did my PhD work in. I did not study the Pheos, though. I studied the neurofibromas, but this is actually a fairly common autosomal dominant genetic disorder. It's caused by pathogenic variants in the NF1 gene and protein, which regulates the MAP kinase pathway. Pheochromocytomas are not part of the clinical diagnostic criteria, but up to 13% have this at autopsy. And if they have hypertension in NF1, you definitely need to screen for pheochromocytoma. These are some of the clinical features: cafe au lait spots, axillary freckling, Lisch nodules, which are benign iris hamartomas, and then neurofibromas that are either cutaneous, subcutaneous, or plexiform. And again, it's recommended in the guidelines that anybody with NF1 who has hypertension or wants to become pregnant should be screened for pheochromocytoma. The second hereditary disorder is multiple endocrine neoplasia type 2, or MEN2. This is caused by activating pathogenic variants in the RET proto-oncogene that activates the PI3 kinase pathway. MEN2 is associated with medullary thyroid cancer, and up to about 50% of patients get pheochromocytoma as well. And it can be bilateral, but it's rarely metastatic. For any fellows in the audience, I just put some pictures of patients with MEN2 because they get the mucosal neuromas around the tongue, eyelids, and this is very pathognomonic really for MEN2. So I wanted to point out those features. And it's recommended to screen for Pheo in people who have MEN at either age 11 or 16 based on the codon that is mutated, whether it's moderate risk or high or highest risk. The third classic cancer predisposition syndrome associated with Pheo is von Hippel-Lindau disease, another autosomal dominant disorder. In this disorder, the VHL protein normally binds to hypoxia-inducible factor and marks it for degradation in the proteasome. But if there's a mutation in VHL or there is the absence of oxygen or hypoxia, this interaction with HIF can't happen. HIF can move to the nucleus and stimulate angiogenesis. Pheochromocytomas are one of the features associated with VHL, occurs in about 20% of patients, and it's recommended to start screening for this at age 5 in patients who have known VHL. The last syndrome I'm going to go into detail about is the hereditary paraganglioma pheochromocytoma syndromes. These are caused by pathogenic germline variants in the succinate dehydrogenase complex, or SDH complex. This is complex 2 of the mitochondrial respiratory chain. It's also involved in the Krebs cycle, taking succinate to fumarate. I have kind of a Twitter war with one of the GI oncologists who do neuroendocrine tumors. He always mocks the Krebs cycle online and social media, and I tell him how important it really is that medical students learn this for this disease. For each of the subunits, if you have a pathogenic variant in A, B, C, D, or AF2, this can predispose to Pheopara. And SDHD and AF2 are associated with paternal inheritance. So again, family history doesn't always help because it skips generations depending on which side of the family it comes from. There are some phenotype, genotype correlations with the SDH, but really a pathogenic variant in any of the SDH subunits can cause a Pheopara really in any location. SDHD is most likely to have multifocal. I have a patient with 11 primary Pheoparas, not metastatic disease, but primary tumors. And SDHB is the one most likely to be associated with metastatic disease, B for bad. It's recommended to screen between ages 6 and 10 with annual biochemistry and full body imaging every 2 years, but we're going to talk about some newer updated guidelines. There are several other genes associated with predisposition, which I don't have time to talk to. I'll just point out that there's also syndromes associated with each of these, and renal cell carcinoma seems to be a common thread through several of the genes that are associated, including VHL and the SDHX. So if I haven't convinced you yet, all patients with Pheopara should be screened for clinical genetic testing because there are a lot of genetic syndromes associated. If I haven't convinced you, I'll show you some more data. This is a study I was not involved in, came out a couple years ago, where they retrospectively looked at a genetic cohort of 125 patients who had genetic testing within 1 year of their Pheopara diagnosis, compared to a cohort of 96 patients they called the historic cohort who had genetic testing but over 7 years after their diagnosis. And what you can see is that the percent survival after metastatic disease was worse for the group who did not know their genetic testing background. This is probably because they weren't being followed as closely. Their disease got more widespread before it was diagnosed. And if you look at the differences after the group knew their genetic testing, those differences resolve themselves. So it's important to have genetic testing. In addition, based on the pathogenic variant you have, it can affect survival. We have cluster 1 tumors, which have NF1 and RET. They have better overall survival than patients who have cluster 2 or SDH or VHL tumors. And then patients who don't have a genetic background fall somewhere in between. And then our own study, we did a retrospective look at progression-free survival after standard chemotherapy for metastatic Pheopara called CVD. And those who had an SDHB pathogenic variant had actually a better progression-free survival. So there may be differences, perhaps, again, this is retrospective, but in response to therapy as well. In the pediatric population, I mentioned 80% have a germline susceptibility gene variant, and about 50% of kids will develop a second primary within 30 years of their initial diagnosis. Again, because they're mostly hereditary conditions and they're more likely to get another tumor at some point in their life. So all these data really emphasize the need for genetic testing and lifelong follow-up because these tumors can occur at any point. So how do you screen patients who maybe are asymptomatic but have been found to have one of these gene variants? Well, we have to think about the genotype-phenotype correlation. I like this as a genetics nerd in VHL. It depends where your mutation is located for what your risk of Pheo is. So if you have a mutation that affects a surface amino acid in the protein, you're more likely to get a Pheo than patients who have mutations that are early stops, deletions, and frame shifts. Now, we don't separate those in clinical real life because most of the time when they're giving you which codon and amino acid, you don't know where in the protein that is. But I just think that that's really cool and no one totally understands why that is. It's more widely known about the genotype-phenotype differences for RET gene variants with MEN2. So what's a little bit hard to see there, but you can, you know that Pheochromocytoma Pheochromocytoma is more common with the 634 codon variant, which is the most common, and it's about 70% risk. But for codon 611, it's only a 15% risk of developing Pheo. So differences depending on the codon change, the amino acid, the DNA change. For SDH-B and D, it was similar we saw initially. So this is a study that came out in 2009, one of the first studies to look at this, and they looked at 358 patients out of the UK. Most of them were proband, so most of them had a tumor already. Very few were the asymptomatic relatives, and they thought that the age-related penetrance for SDH-B and D to develop a Pheopera was almost 100%. So everyone with these mutations was going to get a tumor. But more updated data from the UK or the Netherlands or even the United States, if you separate out the probands and their asymptomatic relatives who were found just on cascade genetic testing, the risk is very different. So if you summarize these when we counsel our patients, if you take the largest studies by age 60 and you look at probands and relatives, that risk can be as high as 60%. But if you look at those asymptomatic relatives that come to your office, their risk is only about 25%. And that's really important because it's different risk estimates that you're counseling your patients about. For metastatic disease, same thing. Used to think it was pretty high in everyone with SDH-B pathogenic variants, but if you look at the Netherlands data and the United States data and separate out those asymptomatic relatives, if you don't have a tumor, your risk of metastatic disease is very low. If you have a tumor, your risk of metastatic disease is going to be higher. But again, it's important how you counsel the patient that comes to you. If they have a tumor, you have to tell them a different risk. And if they don't, because they've read online, SDH-B, B for bad, high risk of metastatic cancer. So if you summarize, I didn't show you the data for A, C, and D, but all the different subunits here, you can see that if you look at probands and non-probands, the two yellow marked columns, these are the risk of developing Pheopera. But if you look at only the asymptomatic relatives, the non-probands, the risk is a little bit different. And you can see for A, B, C, and D subunits, the risk is very different. For SDH-A, that risk is only 10% by age 70. For SDH-D, that risk is 43% by age 60. All the same protein complex, different subunits. Why is the risk so different? So in 2021, a new set of international guidelines came out recommending that because age-related penetrance was not 100%, perhaps we didn't have to screen quite so frequently, and we could space out those intervals to 2 to 3 years for full body imaging, and still about annual for biochemical imaging in adults and every 2 years in kids. But we really wanted to know, could you do this gene specific if the penetrance is so different? So this study was done in collaboration with Toby here at Michigan, with the data that I had when I was at Penn, and Huntsman Cancer Institute at Utah. And we looked at anybody who had SDHX variants. We looked at 263 subjects from 124 families, a median age of 41. And most of these patients had SDH-B variants, but we had patients with SDH-D, C, and A, and AF2. And the follow-up time overall was pretty short, 1.8 years, but we had about half the patients at least had 2 screens, which was usually 3 or 4 years of follow-up, and then 20 some odd patients who had, let's see if we can, there we go, 22% that had at least 5-year follow-up. So here are our results. The tumor positive detection rate, so meaning they had an SDHX related tumor, Pheopera, renal cell carcinoma, or GIST. Those who never had a Pheopera before had 19% tumor detection rate. Those who had one, and we only included people who had really remote history, so they were back to routine screening, 13%. So overall, 17% tumor detection rate. And if you separate it out by gene, SDH-D had the highest, which fits with the other known data. SDH-B and A were kind of in between, and SDH-C was much, much lower. One thing to note is that as we're doing full body imaging in all these patients, we do get false positive results. And we also get incidental actionable findings. And that's the most important because those cause stress for patients when you find something you weren't looking for. And about 15% of the scans showed that. One thing that's interesting is that most of the tumors we found were on the first screen. So if someone is going to have a tumor, we usually pick it up right at their diagnosis, 83%. But there were other patients who we didn't find their tumors till the second or third or ongoing screening. And we also did not identify any of the GIST tumors that can be associated. And that could be due to not picking it up with MRI, full body MRI, and really needing EGD to look at that. And so how many of those might we be missing in our routine screening? We don't know. So this brings me back to this chart where the penetrance is so different. Our data agree with that. So maybe we really need gene-specific guidelines. For my patients who have SDHD, I don't wait 3 years. Their risk is, 43% by age 60. I keep them at every 2 years personally. But those that have SDHA, I don't think they need every 2 years, and I'm not sure they even need every 3 years. Maybe we go every 5 years because their penetrance is so much lower. But that's not official in the guidelines. One thing I'm interested in is studying if there are genetic or environmental modifiers that either everyone with an SH variant, it either increases the risk or maybe protects them from getting tumors. So my current R01 is looking at this, utilizing A5. We have 9 sites across the US and Australia who've contributed samples for this study, including Michigan here. And so stay tuned. We just got our genotyping data back a month ago. So hopefully in the next year, we'll have some results to try to find genetic modifiers. Okay, what about when a patient has a tumor removed? How do we follow them? Well, the answer really depends on the tumor location, if there's known residual disease, if they have a susceptibility gene pathogenic variant, and our guidelines that we put out from NANETS really talks a lot about this in detail. But I would say at least everyone should have annual biochemistries for life once they have a tumor. And then imaging follow-up is really going to depend on the tumor characteristics as well as the genetic characteristics. So I'm briefly going to talk about metastatic Pheochromocytoma now. It's defined a little differently than other cancers. For other cancers, metastasis means invasion through the basement membrane or even local invasion. That's not true for Pheochromocytoma. It has to have distant metastases to be defined as metastatic Pheochromocytoma. It occurs in maybe up to 25%, 15-25% of patients, and it can occur 20 or 40 years after the initial primary tumor diagnosis. And unfortunately, once it's metastatic, we really don't have a cure. We have ways to control the disease, but we do not have a cure. It was thought that the 5-year survival rate was about 50%, with some patients succumbing to disease kind of pretty quickly, and other patients being able to live with it like a chronic illness for over 20 years. And in our more recent retrospective data and 2 other studies that came out the same year, I'm just showing our data though, but our 5-year survival rate in our cohorts were almost 70%. So that really means our patients are able to live with metastatic cancer, pheochromocytoma, for a very long time, and we have to manage their symptoms and the disease. So what are some risk factors? I mentioned the SDHB variant, but in extra-adrenal locations, so something outside the adrenal gland, a young age, a large tumor, these are all risk factors. But we've all had, the ones that take care of Pheochromocytoma patients, metastatic disease from patients who had sporadic tumors, other genetic backgrounds, older patients who present, adrenal cases. So really all patients need that lifelong follow-up because we don't have good predictors for metastatic disease. They've tried to develop histopathological markers, and I think you will agree with me, Tom, that they're not very good right now. So in 2002, they developed the PASS score, and then in 2014, there were papers about the GAP score. These are looking under the microscope, how do you grade different features of the tumor to try and predict who's going to have more metastatic disease. But here's the problem. This study was done for the PASS score. They took 60 cases of adrenal pheo, they gave it to 5 expert pathologists, and they asked them to give a PASS score. And you can see there's huge inter-observer variability over there. Then they gave the 2 most senior pathologists, I know, I'm sorry, Tom, the same 60 cases 6 months later. And if they gave the same PASS score, it'd be on that 0 line, but you can see sometimes that happened, but usually it did not. So there's huge intra-observer variability too. And that's because you may be looking at different parts of the tumor, you may have different slices. It can sometimes be challenging for some of these features to grade. So is the GAP any better? We wanted to find out. So we did a retrospective study where we had 143 patients who had at least 5-year follow-up. So we could have at least 5 years to see if they developed metastatic disease. And we looked at the PASS score and the GAP score as graded by 2 pathologists. And you can see that the PASS score had very low, or I should just say low correlation, 0.6. But the GAP had better. It wasn't great still, but it was better. It was a good correlation at 0.79. And then we looked at recurrence-free survival and disease-specific survival. And the GAP score did correlate significantly with recurrence-free survival. So we think that the GAP score might be a little more useful. That might be because it includes a Ki-67. It's a little more objective. It also includes the catecholamine type secretion, which is, again, a more objective measurement as well. But I would say there's still a lot of variability here, and we really need prospective studies to truly know if the GAP score is going to be any better. And I think ultimately we want to combine the histopathologic features with clinical data and with germline and somatic tumor markers to maybe really be able to better predict who's going to get metastatic disease. So let's dive into some tumor genetic markers. It's been known for a long time that Pheoparas divide into 2 clusters, cluster 1, which is the pseudohypoxia cluster, and cluster 2, which is the kinase signaling cluster. Pseudohypoxia has the tumors that have SDHX and VHL because they activate hypoxia signaling. Cluster 2 is RET, NF1, they activate kinase signaling pathways. So when I was a fellow, I was really interested in trying to understand markers for metastatic potential. We don't have models. There are no mouse models. Okay, that's not true anymore. There are now one that came out last year published. There are some rat models as well, but they're not very matched to the clinical situation. There are no human tumor cell models. So I used human tumor samples and took those that seemed to be clinically benign compared to those that were clinically aggressive and did massively parallel sequencing to try and identify markers of metastatic potential. And what we found, long story short, many years later, is ATRX recurrent somatic mutations. And this stood out to me at the time because ATRX is a chromatin remodeling gene, and it's associated with alternative lengthening of telomeres. And the reason it caught my attention when I was looking over all this sequencing data is at the time it had just been shown to be somatically found in pancreatic neuroendocrine tumors, as well as neuroblastomas and gliomas. So other tumors of kind of neural crest origin seem to have recurrent ATRX mutations. So I looked in a separate cohort of tumors, 103 Pheopara, and about 13% had ATRX mutations, and they were often associated with SDHB germline pathogenic variants and a worse prognosis. So let's talk about telomeres for a second. Most cancers use telomerase. It is an enzyme that helps you maintain your telomeres so the cells can replicate. But a lot of cancers have an alternative lengthening of telomeres method. They may not activate telomerase. Instead, they use this method called ALT. And most of the cancers that do that have mutations or deletions in ATRX or its heterodimerizing partner DAX. And so it's thought to be this homologous recombination mechanism of lengthening the telomeres instead of the telomerase polymerase activation. So we looked at some human Pheoparas and stained them for ATRX and DAX, and you can see that the tumors did not have positive staining in the tumor cells for ATRX, but the blood vessels stained positive. DAX, its heterodimerizing partner, was there. And then we did telomere FISH, where we're looking for long telomeres, and we found that tumors that had ATRX variants had lengthening of telomeres. Thank you for the lights. So that could be one potential marker further for looking for metastatic disease. And this takes me forward to the TCGA, the Cancer Genome Atlas. The NIH wanted to do genomic sequencing on all sorts of different cancers, and they decided to do at least 10 rare cancers, and we were lucky enough to have ACC and Pheopara be included in the rare cancer effort. And these are kind of the summary of the data of the mutations found. So each of these columns is a tumor. There were 173 tumors in the study. Each row is a gene. In this group, we only had 30% of the tumors having germline pathogenic variants in the genes that we knew. About 40% had somatic drivers in the tumor itself. And what you'll notice is they rarely overlap. And that's very uncommon for cancer, but this is a genomically quiet tumor. What I was happy to see is that the ATRX variants were there and they overlapped with germline SDHB variants, which is what we had published right before this. So this was nice to confirm our data. And since then, other people have taken the publicly available data and they've looked at metastasis-free survival and overall survival of tumors, of patients who had tumors that have ATRX variants or telomerase activation or none. So the blue line at the top is the wild type. They do not have ATRX or telomerase, and they have better overall survival and metastasis-free survival than patients who have ATRX or telomerase variants. So this could be an independent prognostic factor, because what's really interesting is that this is from the primary tumor, not the metastasis. So we can identify these changes in the primary tumor, and maybe they would predict metastasis in the future. This study I'm not going to talk about too much, but it just came out this year out of the group from Spain, where they looked at genomic sequencing and they heavily did the metastatic tumors. And again, they found this correlation between ATRX and telomerase variants with more aggressive metastatic disease as a predictor. So very satisfying that this is kind of held true. And I would love to do some sort of prospective trial to see if histopathologically this could be a marker. So back to TCGA, and I'll just point out that 30% of the tumors had no known driver. We still don't know what causes 30% of Pheochromocytoma at all. The other novel thing that came out of this study was these mammal-3 fusions. So these were recurrent fusions that had never been found in Pheochromocytoma before, and we identified them in this cohort. When we did RNA sequencing, all the tumors with the fusion were found in a specific expression group. So we identified the kinase and pseudohypoxia expression that was well known before, but we also identified 2 other expression groups. Not going to talk about the cortical admixture one today. It may just be normal adrenal that got mixed in, but the Wnt altered expression type is where all the mammal-3 fusion tumors were located. They seem to activate this Wnt signaling pathway and had upregulation of mammal-3. So what is mammal-3? Mammal-3 is one of the members of the mastermind-like family of proteins. They're transcriptional co-activators. They bind intracellular Notch in the nucleus and activate transcription of Notch signaling genes like HEY and HES genes. But the fusion that we found has UBTF as the upstream partner with 2 different breakpoints in UBTF, and one of the fusions had TCF4. But no matter what the upstream partner was, the breakpoint in mammal-3 was always the same, always after exon 1, and exon 1 is what contains that Notch binding site. So the mechanism of this fusion probably is not through Notch activation. And we think it's acting through Wnt signaling based on the RNA-seq data that we had from TCGA. The last figure I'll show from TCGA is just looking for associations with metastatic disease. We confirmed a lot of what was known, as I mentioned, but we also found some novel findings, including these mammal-3 fusions and Wnt-altered expression subtype tumors were associated with more aggressive metastatic disease. So this left me with a lot of questions when I was starting my lab. What is this fusion even present in other cohorts of Pheochromocytoma? If it is it actually tumorigenic? And if it's tumorigenic, what's its mechanism of action? And can it be a predictive or prognostic marker for predicting or prognosing metastatic disease? So I'll just show you a little bit of bench data, and these are the people in my lab who've done that. Katrina Cox and Nat Alzafan did the majority of the work I'm going to show you, but also Hannah Haas and Kristen Panwell. And then Nikita Pozdeyev is one of my colleagues who does the bioinformatic analyses. So first, we wanted to confirm that this fusion is even found in another cohort of tumors, and we did in fact find that 7% of our cohort, compared to 5% in TCGA, had these fusions. If you look at it in a different way, every metastatic case, it's about a quarter of the metastatic tumors that have this fusion. Then for the first time, we showed that tumors with the fusion, these are human tumor samples, had upregulation of nuclear expression of mammal-3 compared to human tumors that do not have the fusion. So we set out to create the fusion in vitro and study its function. The fusion is really, really big and it took us a long time to make. So some of the data I'm showing you today that we have published is on either overexpression of the full length construct, which we call FL in all the figures, versus what we call delta exon 1, where we've knocked out the notch binding site in exon 1 to mimic the fusion. We now have stable cells with the fusion, and the data I'm not going to show you because it's unpublished, but it's very similar to these data. So we showed that it maintains its nuclear localization. And then we showed that there's increased viability in 3 different cell lines in the cells that have, I'm sorry, that's blocking the way, but the lower bar, the first bar is the vector, and then we have full length and then the delta construct. So increased viability in those cells that overexpress mammal3, full length or delta. But we do not see an increase in proliferation or apoptosis. That tells us that this is probably not a tumorigenic event that's happening. But when we did invasion through Matrigel in Bowden chamber assays or soft agar colony formation assays, we did show that there was increase in invasion and increase in soft agar colony formation with overexpression of full length or delta mammal3. So how is this happening? Well, we thought we should look at beta-catenin and Wnt signaling based on the TCGA data. So these are those same tumors I showed you before with the mammal3 staining, and now we're staining these human tumors with beta-catenin. And you can see the fusion positive tumors have increase in beta-catenin, mostly membranous, but if you look really closely, there's some nuclear and cytoplasmic increase as well, but certainly it's largely increased compared to the fusion negative tumors. And then we did luciferase assays with TCF-left promoters, which are Wnt signaling gene promoters, and showed that if we co-transfect beta-catenin in either full-length or delta mammal3, we get huge increases in promoter activation. And the one solitary gray bar over there is beta-catenin alone. So beta-catenin does it a little bit, and then it's greatly increased with mammal3. And by co-immunoprecipitation assay, we showed that beta-catenin and mammal3 are in the same complex. We then did RNA-seq in our cell lines. So we have 3 different cell lines that are very different. So we use that as a variable as a covariate to account for. And when we did that, we showed that some of the most highly upregulated pathways that are common to increase mammal3 across the cell lines are the Wnt and the hedgehog signaling pathways, very similar to the human tumor sample. So we think what's happening is that normally on your left, the mammal3 is binding to intercellular notch and activating notch signaling pathways. But when you have the fusion or overexpression of full-length mammal3, it may be also able to interact with beta-catenin in some way and activate Wnt signaling genes. Of course, we didn't show yet the fusion if it acts the same way or differently, but again, we're doing that now and have shown increased invasion and migration with the fusion as well. And we're investigating this in vitro and in vivo. So in summary, alpha blockade uses ozone. Don't worry about trying to get your hands on phenoxybenzamine, just titrate that doxazosine real well. About 30 to 40% of patients with Pheopara have a susceptibility gene pathogenic variant in one of at least over 12 different susceptibility genes. So all patients with Pheopara should be referred for genetic testing, and they need lifelong follow-up because they have a risk of additional primary tumors as well as metastatic disease. We talked today about the 2 clusters that were known, pseudohypoxia and kinase signaling. We talked about how knowing the genetic background can make a difference in prognosis as well as maybe response to therapy. We talked about how ATRX mutations and TERT alterations also play a role potentially in prognosis, and how mammal3 may as well. So knowing cluster 1, 2, and 3 can have prognostic and therapeutic implications potentially. So I just want to thank everyone in my lab, as well as my collaborators, including those here at the University of Michigan. All of the A5, we couldn't do a lot of our current studies without the international collaborations and our funding sources. So thank you very much.
Thank you. Any questions?
Oh, good question. So in the TCGA ones where we know initially, we looked at Ki-67, but not a full gap because we only had one frozen section. Ki-67 did seem to correlate, but the numbers are so small, right? We had about 15 cases on ML3. And then in our own study, also just the numbers are real small. So this is something that I want to do. What I would love to do as an A5 study is get some sections of tumors stained for HERX also, stained for mammal3, stained for Ki-67, and then H&E, and do a lot of these type of proposed studies.
Do you do with arrays, or do you think you need whole sections?
I mean, for the staining correlating to outcome, we probably can do arrays. For gap score, I'm a little wary about doing that on just on TMA.
So the VHL mortality surprises me because those tumors aren't commonly metastatic. Are they dying of other tumors that are associated with VHL?
Yeah. So that's more of the renal cell and hemangioblastomas and things. Those weren't just plain Pheochromocytoma. Thank you for pointing that out. It's important.
Certainly the androgenase of complex, these are all loss of function mutations.
Yes.
And is the magnitude of the loss of function correlated with this?
Oh, it's an excellent question. And I'm not sure anybody really knows that answer. So we don't, so there's a study right now, JP's doing out of Europe, where he's really trying to look at genotype phenotype correlation. The initial studies didn't show a lot of genotype, like specific variant and what the phenotype was, but he's trying to get together much larger numbers to take a look at that. So hopefully we'll know a little bit more.
These subunit is not a subunit in the functionality of the
Yes, so this is aim 3 of my R01 to try and look at some of how these proteins fit together, and they do have different functions. So 2 of the subunits are more anchoring to the mitochondrial membrane. 2 of them have more transfer of electron through and stuff. So they do have different functions to them, and it may be associated with that, but that still doesn't explain why SDHB is not fully penetrant at all, and why not everyone with SHB gets metastatic disease either. So I don't know the answer, but we're working on it.
Go ahead, sorry. Go ahead. Fine,
Is this characteristic of not being able to shorten the telomeres, but instead of lengthening the telomeres, the characteristic of metastatic endocrine tumors or other tumors?
So all cancers, because the cells divide so quickly, the telomeres are like caps. And so if they get shortened, you get into the important DNA, and then the cell triggers apoptosis and it dies. So that's the normal mechanism for cell death. It can only do so many divisions, but cancer cells use telomerase to maintain. They actually don't lengthen the telomere that much. It just maintains it. But this alternative lengthening of telomere, they do actually get pretty long telomeres at the ends. And it's any and all cancers use some mechanism. Mostly though, it's telomerase. Only about 15 to 25% of cancers use this alternative lengthening of telomeres. So we don't know exactly how it works, other than it allows the cell to keep dividing without getting into that important part of the DNA.
The analysis regulated in the cells that have this mutation?
Yeah, so another good question. They do have some deficiencies in the tumors themselves where they get succinate built up. And so normally this complex takes succinate to fumarate. So there are a lot of people who are doing like serum analysis for succinate and also imaging techniques for succinate, because you are messing up glycolysis that way. And there are other pheochromocytoma genes in the Krebs cycle. So MDH2, FH, they all contribute to Pheochromocytoma as well. And it's that buildup, and those metabolites build up and we think lead to the hypermethylation in those tumors and lead to tumorigenesis through some mechanism via that.
Couple of clinical questions.
Yes.
Do we need to block it all?
You had to ask me this. So the people in Germany have published studies saying you don't need to block anybody before surgery with Pheochromocytoma, no matter how high their hormone levels are. And what I would say is, yes, if you have that anesthesiologist and that surgeon who do all their Pheoparas and they know how to do this and they hang preemptive meds and they're used to it, then yeah, I think a lot of what we do is probably just making us feel better ahead of time. But I would argue that not everybody who's doing surgery on Pheoparas knows how to handle them during an operation. And so a blockade we give them, I think, does help and matter. So I say yes, because it scares me to think what might happen certain places without it.
So I've got one more question, which is, probably for you a common scenario as well. You already commented on the different SDHs and different names, right? So what do you tell a 56-year-old woman with breast cancer, early stage, completely removed on a large panel? She's found to have SDHA. Let's even say the R31X, which is actually present in 1 in 3,000 people. Does she need surveillance at all? No family history, no personal history of Pheopara, and how often would you repeat it?
Yeah, almost all my SDHA pathogenic variant carriers come in this exact scenario after their breast cancer diagnosis and a huge gene panel, and then they find they have SDHA. So what I tell them is that we're still learning and finding data and learning more every year. And that right now I recommend at least a baseline screening. And if we find nothing else on the baseline screening, then come back and see me in a few years and I'll let you know if we have more data information. So I actually don't give them specific timeline of when they should re-image, but I tell them come back and see me in 2 or 3 years so that we can discuss it further. And at that time, what I've been doing, so I'm just getting around to some of those patients now for their second screen, is at least do biochemical testing. I don't necessarily do the full body because I just don't want to miss a secreting one on the off chance they have it.
Any other questions? Here's the chat question. Oh, there's a chat question.
Hi.
Yes,
Oh,
Amy.
Oh,
Yeah,
so
hi.
exciting.
I'll just unmute myself if that's okay. So with respect to SDHB, and you mentioned for those who have that mutation, it's almost always bad. Can you hear me?
Yes.
Okay. So is the screening any different in them? Is all the screening basically anchored on that particular mutation? So that every 2 years and the every 6 months, or because I'm just worried if, it's so bad, what happens? I don't know how aggressive it
What
is.
you're asking is for SDHB variants, how often should we screen them? And should we do it
Yes, how often
differently?
exactly?
Yeah. So it depends if they have had a tumor or not had a tumor. So if they've never had a tumor and they just have an SDHB variant, then my practice is once a year biochemical testing, every 2-year full body imaging. And I still use MRI because there's less radiation. There are some places that are moving to a dotatate scan because they think for SDHB, they should catch anything and everything early. My argument not to do that is largely on cost. It's so expensive, a dotatate PET scan, and it's not always covered by insurance well. The other reason I think not to do it is lead time bias and false positives. And I just worry that you're picking up stuff that you don't necessarily need to know about. Now that's different if I have a patient with SDHB who's had a tumor or had multiple primary tumors. That's a different scenario. When I'm worried about potential metastatic disease, I will order that dotatate PET scan, very quickly. So it really depends if the patient has had a tumor or not had a tumor. And again, for the other gene subunits, for SDHA, I really space it out. I don't do it that often. For SDHD, I keep it at every 2 years if they've not had a tumor before. And SDHC, that's harder. We just don't have as much data. So I tell them about every 2 to 3 years, whatever they're kind of comfortable with.
Any other questions for Yes.
Yeah, thanks for asking that. I had a slide and took it out for time. No. And the reason no is because it's so falsely positive. Any PPI, I had a patient once who had a chromogranin in 10,000 and it was all the PPI. And H2 blockers can increase, irritable bowel syndrome can increase, kidney disease, liver disease. I do not check chromograninase. Now, if you really ask me in my practice and look at every single chart, there are some patients that I check a chromogranin A. But in general, for screening, I absolutely do not. Sometimes I'll use it to follow people who have metastatic Pheopara that are not secreting. So I just use it to see if it massively goes up or something like that. But in general, I do not, because it gives the patient so much anxiety to see a high chromogranin A, and what are you doing with that information? So I don't check it. And the guidelines for pancreatic neuroendocrine tumors from NANETS, we actually said in there, don't check it specifically. And in the Pheopara, we strongly recommended sort of not to as well. I don't think it's helpful. I think it stresses people out more than it's useful.
Actually, I've got one last question, and that is, so how much do you actually believe that SDHB is truly what confers a higher risk for a malignant phenotype? If you look at TCGA, those were all abdominal paragangliomas because they excluded head and neck. There's a larger European series just recently looking at head and neck. SDHB doesn't fall out as being more common malignant. Could this be rather a function of where the tumor arises, or do you truly think it's SDHB?
I think that it's a combination of what Peter was asking before, that there are probably the variant-specific information in there. I think it's partly how well it holds that whole complex together versus whether the whole complex falls apart. That's my hypothesis. I don't know that that's true. I think location, I don't know if location plays a role as much as other genetic modifiers and other variants in the complex that allow that particular variant to hang on versus come apart. That's my hypothesis, but it's not based on any data. But location is hard for me because, okay, yeah, these are more parasympathetic, these are going to be more sympathetic, but I have a hard time sussing out why that would make a drastic difference.
For a patient that have no secretory paraganglioma field, is periodic biochemical screening help decrease the frequency of re-imaging, or do them independently?
So let me make sure I have the question correct and for the people on Zoom. So the question is, if someone had a paraganglioma or pheo that's SDHB associated, would just doing more frequent biochemical testing alleviate the need for some imaging? So the imaging part of that is hard. So if a patient just has a solitary tumor, it was 3 centimeters, whether it was a pheo or para, it was removed fully, their catecholamines went from high to back to normal, then I don't necessarily image them more than I would just because they're an SDHB carrier. So every 2 years, I don't necessarily do a 6-month or an annual follow-up for a small pheo para that was removed. I will do their biochemical testing every year and make sure. On the other hand, if it was a large 13 centimeter paraganglioma SDHB that maybe was, kind of wrapped around the aorta a little bit or something, then I do image again. I don't know how useful the imaging is because it's such a slow growing tumor, but I think it makes the patient and myself feel better to do the imaging plus the catecholamines at a 6 to 12 month mark. The problem of just using biochemical testing is that patients can develop another primary, and their next primary might be non-secreting. So you have to throw in imaging somewhere in there. And the interval is this question that we're all trying to kind of figure out.
That's a rather critical question. What do you thoughts or opinions on the use of hydroxychloroquine in head and neck paraganglia?
Yeah, so the question is whether to use hydroxychloroquine as a marker, especially for the head and neck paraganglioma. So my European colleagues and I had some debates about this. So it's a tough one. So the first thing I'll say is it's not readily available in most centers in the US. So most people can't get it. My argument always is, why can't you just use dopamine? Because you get that on plasma catecholamines or 24-hour urine catecholamines, they're metabolites. Like, why not just use dopamine? So that's what I do, is just use dopamine. I don't know what it tells us that much though. So the papers that are out there, which are mostly all from one group, do show that it's associated with higher risk of metastatic disease potentially. Those data though are a little bit hard. They're retrospective. Again, they're all from one group. So I don't know yet. I think, the jury is still out on that. I don't tend to check plasma catecholamines or 24-hour urine catecholamines when I'm screening for Pheopara. You're going to get a lot of false positives. I just use metanephrines. But in my SDH carriers, especially with head and neck, sometimes I send the catecholamines. I just want to know if they're dopamine secreting. Most patients, though, don't have many side effects from dopamine, but every once in a while, I'll have a patient that does.
I can tell you the first 400 patients when we actually switched gear to mass spec, they had on the back end, they did metanephrine, normetanephrine, and proxytyramine. They got rid of that after a while. But on the first 400 patients, there was one positive, and that was a patient with also sky-high normetanephrine, no metastatic SDHB related paraganglioma, nothing else, right? So
Yeah, I haven't bought in yet, I will say, but trying to be nice by saying that the jury's still out.
okay. Thank you very much.
Thank you.